Roughly 1 in 3 patients who die in a hospital have this condition. 1 in 3.
Yeah, it's a completely staggering statistic.
It really is, and yet this remains one of the most widely misunderstood medical emergencies on the planet. Welcome to today's deep dive, designed specifically for you.
We really want to cut through the medical jargon today and deliver those essential aha moments.
Exactly, because today we are looking at sepsis. And the mission for this deep dive is to look at a stack of nursing and medical research to understand this deadly biological overreaction.
Right, we're going to uncover what sepsis actually is at a cellular level, how its definition was controversially engineered, and why recognizing it early is literally a matter of life or death for you or your loved ones.
Because we're not just talking about some niche ICU textbook topic here. Sepsis costs the healthcare system tens of billions of dollars annually.
Oh, absolutely.
Yeah.
And it played a massive role in the COVID-19 pandemic, too.
Right. What we now understand is viral sepsis.
Exactly. And surviving it often relies on bystanders and bedside nurses spotting the very first really subtle signs.
But before we talk about how to spot it, or, the fierce medical debates surrounding how to treat it, we need to strip away a massive layer of public confusion.
Yeah, the misconceptions are everywhere with this one.
I mean, the common perception is that sepsis is just blood poisoning, right? Or just a really, really bad infection.
Right, but that's actually not accurate. A substantial proportion of clinically diagnosed sepsis cases involve blood cultures that come back completely negative.
Wait, really? Completely negative?
Completely. There are no detectable bacteria in the bloodstream at all in those cases. The infection might be highly localized, like a pneumonia in the lungs or a urinary tract infection.
Okay, so if the bacteria aren't swimming around in the blood, what's actually happening?
Well, the 2016 Sepsis 3 criteria officially defines it as a life-threatening organ dysfunction caused by a dysregulated host response to infection.
A dysregulated host response. So it's not the bug.
Exactly. It's not the invading bug that ultimately kills a person. It is their own body's reaction to it.
Okay, so to understand this from first principles, let's think about how the immune system normally operates.
Right. So normally it detects a threat, mounts a localized proportional response to eradicate the pathogen, and then it stands down.
So if I get a splinter, my finger gets red and swollen because the immune system is sending white blood cells to that specific spot.
Precisely. It's localized inflammation. But in sepsis, that response fails to stay contained.
It just goes rogue.
It does. Instead of a targeted attack, the body launches a systemic chemical storm. It floods the entire bloodstream with inflammatory signaling molecules called cytokines.
And the research highlighted 2 main culprits there.
Yeah, interleukin-6 and tumor necrosis factor alpha. These molecules are essentially biological alarm bells. But in sepsis, the alarm gets stuck in the on position.
Just blasting system-wide.
Exactly.
Okay, let's unpack this for a second. It's kind of like calling in a SWAT team for a minor noise complaint, and they end up bulldozing your entire neighborhood.
That is a perfect analogy.
I mean, the infection isn't destroying the house. The body's own security system is indiscriminately wrecking the infrastructure.
And the way that infrastructure gets wrecked is fascinating, but also terrifying. Those cytokines tell blood vessels all over the body to dilate, to open up and become permeable.
So they get leaky.
Right. The physiological purpose is to let immune cells slip out of the bloodstream and into the infected tissues. But when this happens everywhere at once, fluid leaks out of the vascular system.
It's like a municipal water system where every single pipe suddenly springs a leak.
Which means blood pressure plummets system-wide.
And if there's no pressure in the pipes, the blood just can't circulate effectively.
Exactly. And compounding that low pressure is another phenomenon called DIC, or disseminated intravascular coagulation.
That sounds intense. What does that mean?
Basically, the massive inflammation confuses the body's coagulation system. So, microscopic blood clots begin to form inside the small blood vessels.
Wait, so the pipes are leaking, dropping the pressure, and simultaneously thousands of tiny blockages are forming inside whatever pipes are left.
You've got it. That means the blood-carrying oxygen simply cannot reach the body's organs.
The clinical term for that is hypoperfusion, right?
Right. Hypoperfusion. Vital organs like the kidneys, liver, lungs, and brain are starved of oxygen.
So they just begin to fail.
Yeah, they start shutting down, even though the organs themselves were never actually touched by the original bacterial or viral infection.
Wow, it really changes how you look at a diagnosis. I mean, we usually expect things in medicine to be binary. A broken arm is broken, a tumor is there, or it isn't.
Right. It's usually very clear-cut.
But knowing that sepsis is this massive, chaotic cascade, this chemical storm, it raises a huge question about how doctors ever figured out how to uniformly diagnose it.
Oh, the history of how they figured it out involves a surprising amount of bureaucracy.
How so? Like, how do you put a hard clinical label on a chain reaction?
Well, to find the origin of the modern sepsis diagnosis, you really have to look at the landscape of critical care research back in the 1980s.
Okay, what was happening then?
Researchers were running extensive clinical trials for new anti-inflammatory drugs, trying to find a way to switch off that cytokine storm we just talked about.
Right, trying to stop the SWAT team.
Exactly. But the trials were failing, or the data was just completely uninterpretable.
Let me guess, because different hospitals were using entirely different definitions of what the storm actually looked like.
Spot on. There was zero shared vocabulary. One hospital might define a patient as having sepsis based on a high fever and low blood pressure.
And another hospital.
Another might require positive blood cultures. So researchers couldn't test if a drug worked because they couldn't guarantee they were treating the same disease across different patient groups.
Hold on, let me get this straight. You're telling me sepsis isn't some ancient, discrete disease category like malaria or tuberculosis?
Not in the way we diagnose it today, no.
It's basically a bureaucratic checklist that scientists invented in the 90s just so their pharmaceutical trials could have a baseline.
It's wild. But yes, an administrative tool created for clinical trials absolutely morphed into a daily clinical reality.
That is fascinating.
Yeah, so in August 1991, in Chicago, the American College of Chest Physicians and the Society of Critical Care Medicine held this big consensus conference.
Chaired by Dr. Roger Byrne, right?
Right, Dr. Bone. Their explicit goal was to invent a standardized apples-to-apples checklist. They created what we now call Sepsis 1.
And what was actually on that checklist?
They defined it as a known or suspected infection plus SIRS.
SIRS, that's S-I-R-S.
Right, which stands for Systemic Inflammatory Response Syndrome. It was this crude 4-point metric.
What were the 4 points?
Abnormal temperature, elevated heart rate, high respiratory rate, and an abnormal white blood cell count.
Yeah.
If a patient had an infection and met 2 of those 4 criteria, boom, they had sepsis.
And if it got worse?
If their organs started failing, they were bumped up to a category called severe sepsis.
But medical understanding obviously didn't stop in 1991. The criteria we use today, Sepsis 3, they completely threw that SIRS checklist out the window, didn't they?
They really did. In 2016, a task force led by Dr. Mervyn Singer fundamentally overhauled the definition because the old SIRS criteria were simply too sensitive.
Because it caught sepsis, but it caught everything else too.
Exactly. The inflammation checklist was way too broad.
I mean, think about it. If you just went for a brisk jog on a hot summer day, your heart rate goes up, your respiratory rate goes up, your temperature goes up.
Yep, technically a jogger could meet the criteria for systemic inflammation.
Diagnosing a healthy person who just ran 3 miles with a life-threatening medical emergency kind of proves the system was flawed.
Which is exactly why Sepsis 3 replaced the SIRS inflammation checklist with something called the SOFA score.
The sequential organ failure assessment.
Right. The entire philosophy shifted in 2016. Sepsis is no longer defined by the initial inflammation. It is strictly defined by an acute drop in organ function.
Which is why they retired the term severe sepsis altogether.
Yes. Under the 2016 rules, if you have sepsis, organ dysfunction is already happening. The severity is just baked right into the new definition.
And didn't they redefine septic shock too?
They did. They rigidly redefined septic shock to mean a state where blood pressure is dangerously low despite aggressive intravenous fluids.
So you have to use drugs to fix it.
Right, requiring specific drugs called vasopressors to manually squeeze the blood vessels and force the pressure back up.
But this shift created massive tension in emergency departments, didn't it?
Oh, huge tension. Because if you screen for sepsis based on early inflammation, using that old 1991 checklist, it's really easy to spot at the bedside.
But you might trigger false alarms.
Exactly. But if you wait to screen based on the new 2016 definition of organ dysfunction, you're dealing with a much more accurate prediction of who might die.
But you might be catching it way too late.
And getting it right at the bedside is a literal race against the clock. The time factor is what makes these academic debates over definitions so critical in the real world.
Yeah, and the reality of how fast this moves is perfectly illustrated by the story of Rory Staunton.
That case is just heartbreaking.
It really is. In 2012, Rory was a completely healthy 12-year-old boy living in New York City, and he scraped his arm in gym class. Just a normal, everyday scrape.
Something that happens 1,000 times a day.
Right. But over the next few days, he developed a fever, worsening pain, and he started vomiting. So his parents took him to the emergency room.
And he presented with abnormal vital signs and lab values that suggested an escalating infection.
But because he was a healthy-looking child, the subtle indicators of early sepsis were misinterpreted.
They completely missed the systemic response.
The hospital actually discharged him with a diagnosis of a stomach virus and dehydration.
Well,
He went home, his condition rapidly deteriorated, and he returned to the hospital in septic shock. He died just days later. It's devastating, and it completely dismantles the idea that sepsis only happens to the frail or the elderly or people who are already severely immunocompromised in an ICU.
it can kill a healthy child in a matter of days.
It can. And following incredible investigative reporting that highlighted how easily those subtle lab values are overlooked in busy ERs, New York State took action.
They adopted Rory's regulations in 2013.
Right. The law mandated that all hospitals in the state implement and rigidly follow protocols for the early identification and rapid treatment of sepsis.
Because every single minute counts. I mean, Dr. Anand Kumar published a landmark study back in 2006 looking at patients who had entered septic shock.
The gold hour study.
Yeah. The data revealed that for every single hour of delay in getting effective antibiotics into the patient's system, survival drops by an average of roughly 7.6%.
Think about that number for a second. A nearly 8% drop in the chance of survival for every 60 minutes that pass without the right medication.
It's terrifying. We usually think of a heart attack or a stroke as a time-is-tissue emergency. Right, where you have to get the clot-busting drug in fast to save the heart muscle or the brain.
But this data proves sepsis is exactly the same kind of ticking clock. The organs are suffocating and the clock is running.
And those terrifying statistics birthed one of the most significant interventions in modern medicine, which is the Surviving Sepsis Campaign's Hour 1 bundle.
Okay, so what actually happens in that first hour? Walk us through the bundle.
It is a rigid, time-based protocol dictating 4 immediate actions upon recognizing sepsis. First, measure the patient's blood lactate levels.
Let's explain why lactate matters here. When organs are starved of oxygen because the blood pressure has dropped, the cells don't just stop working immediately.
Right, they try to compensate.
They switch to an emergency backup generator called anaerobic metabolism.
No.
And a byproduct of that backup system is lactic acid.
So high lactate in the blood is a direct indicator that the body's tissues are literally suffocating.
Okay, so that's step 1. What's step 2?
The second step is to draw blood cultures to try and identify the specific bacteria. And that's followed immediately by step 3, which is administering broad-spectrum antibiotics.
So you don't wait for the culture results to come back?
No, absolutely not. You use a powerful drug immediately to try and neutralize whatever might be causing the cascade.
And the final step?
Step 4 is pushing rapid, aggressive intravenous fluids, often 30 milliliters per kilogram of body weight.
That's a lot of fluid.
It is. The goal is to forcefully refill those leaky pipes and push the blood pressure back up.
I mean, it sounds like the perfect, logical solution to the ticking clock. Identify the oxygen starvation, hit it with antibiotics, and pump up the pressure in the first 60 minutes.
It does sound perfect on paper.
But enforcing this rigid, one-size-fits-all bundle has actually sparked intense institutional turf wars, hasn't it?
Oh, massive controversy. The Infectious Diseases Society of America, the IDSA, fundamentally refused to endorse the Surviving Sepsis Campaign's guidelines regarding that rigid 1-hour timeline.
Pushing back against treating a deadly condition in the first hour seems kind of counterintuitive. Why the resistance?
It comes down to the danger of medical dogma. Mandating broad-spectrum antibiotics on a rigid 1-hour clock, often before an infection is even definitively confirmed, carries enormous risks.
Like driving antibiotic resistance on a macro level, which we know is a massive global health threat.
Exactly. But on a micro level, for the patient sitting in the ER, blindly rushing into the sepsis protocol can be dangerous because of mimics.
Mimics, meaning conditions that look exactly like the cytokine storm but require completely different treatments.
Right. Severe pancreatitis, adverse drug reactions, or even just severe dehydration can present with the exact same inflammatory signs as early sepsis.
So if an ER physician is terrified of violating a state-mandated protocol, they might just put blinders on.
They just push antibiotics and massive fluids, and they might completely miss the real diagnosis.
You definitely don't want to enforce a rule so strictly that doctors are penalized for taking an extra 20 minutes to think critically.
And this friction applies to the screening tools, too. When Sepsis 3 was introduced, they created a quick bedside checklist called QS-OFERAT.
The quick SOFA.
Right. It only looks at three things: altered mental status, high respiratory rate, and low blood pressure.
The intention there was to give busy triage nurses a really fast, simple tool, right?
It was. But extensive follow-up studies proved that QSOFA is a relatively blunt instrument for early detection.
Meaning it's highly specific for predicting mortality, so if you trigger the QSOFA alert, you are likely already very sick.
Exactly. But it misses a significant number of patients who are in the crucial early stages of the cascade.
Which totally explains why many hospitals stubbornly refuse to give up the old 1991 SIRS criteria. The academic definitions evolve, but the bedside realities demand a wider net.
You need that wider net to catch people before their organs start failing. And honestly, the debates aren't just about screening. The core assumptions of the treatments themselves have been challenged.
Right, like the FEAST trial from 2011.
Yes. Led by Dr. Catherine Maitland in sub-Saharan Africa. This trial tested a core assumption of the sepsis bundle pushing rapid, large volumes of intravenous fluid into critically ill children with severe febrile illness.
Because the physiological assumption is that more fluid equals better circulation, which equals better outcomes.
It's practically a religion in Western medicine.
But when they ran the trial with children in Kenya, Uganda, and Tanzania, the results were incredibly counterintuitive.
They were shocking.
The children who received the rapid fluid boluses actually had a higher mortality rate than those who didn't. The rapid fluids killed them faster.
Yeah. And the underlying mechanism of that failure requires a lot of intellectual humility from the medical community.
Why did it fail?
When you push massive amounts of fluid into leaky blood vessels, that fluid often backs up into the lungs. It's a condition called pulmonary edema.
Okay, but we give fluids like that in the U.S. all the time.
Right, but in a high-resource Western ICU, if a patient develops pulmonary edema from fluid resuscitation, the clinical team simply places a breathing tube.
They connect them to a mechanical ventilator until the fluid clears. So the machine does the breathing while the body processes the extra fluid.
Exactly. But in many of the hospitals participating in the FEAST trial, mechanical ventilators simply were not available.
Oh, wow. So the aggressive fluid protocol flooded their systems, and without the technological safety net of a ventilator, they couldn't survive the intervention.
A deeply entrenched physiological assumption failed completely in a resource-limited context.
It really highlights the fundamental tightrope clinicians walk every single day.
It does. State mandates and rigid protocols can lead to protocol fatigue, where alarms go off constantly for patients with simple viral illnesses.
Which leads to unnecessary treatments and physician burnout. But on the flip side, if you remove the protocols and rely entirely on individual subjective doctor judgment in a chaotic ER,
You get cases like Rory Staunton. Subtle clues are missed, and healthy people are sent home to die.
the challenge is navigating that space between absolute rules and individual clinical nuance.
It's an incredibly difficult balance.
So bringing all of this together, what does this mean for you, the listener, navigating the healthcare system? First, understand that sepsis is your body's devastating overreaction to an infection.
It's the internal security system destroying the infrastructure.
Second, the way we define and measure that destruction is constantly shifting, balancing the need to act fast against the need to be accurate.
And third, time truly is tissue. A delay in effective antibiotics actively diminishes the chances of survival hour by hour.
But as the FEAST trial demonstrated, the treatment protocol is not universally applicable in every context. Medical interventions always carry trade-offs.
Always. But this knowledge is deeply empowering.
Yeah, it really is. Public health campaigns like the UK Sepsis Trust's Just Ask, Could It Be Sepsis exist because this is one of the few medical emergencies where a vigilant bystander can change the outcome.
Absolutely. If you are in an ER waiting room and notice a loved one exhibiting subtle signs, a sudden change in mental status, or breathing just a little too fast.
Or just a profound sense that they don't look right.
Right. Asking that specific question to a triage nurse, could it be sepsis, can literally trigger the bundle and save their life.
The informed advocate at the bedside is often the most vital link in the chain of survival.
They really are.
But there is a final, lingering reality of this biological storm to consider. We explored how the immune system overreacts, flooding the body with inflammatory cytokines.
Initial fire, essentially.
Right. But we haven't talked about what happens when the storm finally breaks.
Ah, right. Because sepsis survivors often enter a phase called CARS, or compensatory anti-inflammatory response syndrome.
The body basically realizes it's destroying itself and throws the emergency brake.
But it pulls the brakes so hard that the immune system swings completely in the opposite direction.
It plunges the patient into profound immune suppression.
Yeah, they survive the initial explosive overreaction, only to be left entirely defenseless against every other pathogen in the environment.
So here is the question to mull over long after this deep dive ends.
Let's hear it.
If we know that sepsis survivors are walking out of the ICU and into this quiet, deadly phase of vulnerability that lasts for weeks,
Right.
why is our medical system so fiercely focused on engineering definitions for the first hour of survival and seemingly so poorly equipped to protect and monitor these patients during the dangerous recovery that follows?
It's a sobering thought. We obsess over surviving the initial chemical fire.
But perhaps we need to learn how to navigate the devastating silence that comes after.